Let's start. We will rearrange the plan of our lectures a little bit, but actually it won't affect the result anyhow. So today we will have a lecture about the topics of the second semester. It is minimally invasive surgery. So I told you we'll have lectures only in the first semester. So for this, during these lectures, we should study all the topics of both first this semester and the next autumn semester. Okay, so this lecture will be about minimally invasive surgery. So we will discuss contemporary methods of surgical interventions on thoracic, abdominal, and pelvic organs. And yes, and today we'll talk about it, and we will see that actually these methods are not so much new, are not as new as we used to think about them. Okay, so what is minimally invasive surgery, or MIS? So minimally invasive surgery, it is a surgical intervention with an approach through natural orifices. In this case, we call it endoscopy, or small incisions, not more than 1.5 centimeters. If the incision is more than 1.5 centimeters, then it will be mini laparotomy, mini thoracotomy, but it won't be scopy, it won't be minimally invasive surgery. So usually incisions do not exceed 1.5 centimeters in the length. So what were the facts which caused development of minimally invasive surgery? And so all of us understand, yes, reduction of incision size was a dream of all surgeons for centuries, because all of us know that the worst thing, actually usually patients are not so much interested in what is inside them, they care much more about what is outside. So before the surgery, patients, all, especially women, yes, female patients, they always ask, and so how will it look like after the surgery? Will I have the ugly scar after that? And after big surgeries, yes, usually scar is left, and sometimes it's very ugly, and it's not quite nice. But actually, what we see from outside, it is like the very last thing surgeons should think about, because if we see such ugly scars on the skin of the patient, just imagine what is inside, yes, and adhesions inside the cavities, inside the abdominal, pelvic, thoracic cavity, they are not visible, but they may cause very severe complications in postoperative period. That's why the less the incision is, the better it is for the patient, but the harder it is for the surgeon, and we will see it today. And yes, who should especially care about this? Actually, any specialist, but if for surgeons, for general surgeons, those who perform surgeries on the intestines, these adhesions, they will cause intestinal obstruction, and patient will notice it at once, and so symptoms will be very severe. Then for the gynecologist, it is even more dangerous, because women won't have so many complaints, but finally we know that any adhesions, even the smallest adhesions in their reproductive organs, they will finally cause infertility in females. So as I told you, it is not such a new method. Actually, the most primitive minimally invasive methods, they existed very long ago. And so 400 years before Christ, yes, at the time of Hippocrates, he described rectal speculum. So special device which he inserted into the rectum, and he was looking inside, and he saw mucosa of rectum, and he could examine it. Then in the 11th century, Al-Buqasim, a Arab physician, he invented speculum illuminated by a set of light reflectors. So, but as we later say, yes, all of these light reflectors, they gave much warmth, and that's why they caused burns, but they didn't give much light. And that's why this reflector, yes, it was used for some experiments, but complications after using it were very severe. So then, yes, then in 1806, Philippe Bassini invented Lichtleiter. So here, he was, this Bassini, he was a German. He invented Lichtleiter. Here you can see it. So it is a special device that also allowed to examine urinary bladder, for example, and it was used in animals. But like it had a tube, as you see here, and it had a reflector. And again, it was just a candle, and we know that candles, they do not give much light. That's why not so many things were visible, but burns, because it gives much warmth, they were complications of it. And then in 1953, Anthony Jean de Jarmeur, he invented cystoscope. So cysta means urinary bladder, you know, yes, scope means to watch, to observe. And in 1883, David Newman placed Edison's lamp into cystoscope. Yes, so he substituted candle to Edison's lamp, and yes, results were much better because lamps, they give much more light, but still it was warm light that caused burns. In 1901, so Russian surgeons, as always, are not the last in the development of minimally invasive surgery. So in 1901, Dmitry Ott, and he is actually gynecologist, Russian gynecologist, he performed the first ventroscopy. The speculum was introduced through a prior incision in posterior vaginal wall in pregnant woman. And so here you can see it, ventroscopy. So just through the vagina, yes, there was an incision was made in the posterior vaginal wall, and this ventroscope was introduced, and we could observe uterus and some abdominal organs, so in pregnant woman. And so just imagine how complicated it was, because uterus occupied nearly the whole abdominal cavity, but he did it. So then in 1902, Georg Kelling from Germany, he performed the first laparoscopy in dogs. So laparoscopy, it's absolutely clear what is this. Yes, scope to scopy means to observe. Lapara means abdomen. So observation of abdominal cavity. And then in 1911, the first laparoscopy in humans was done by Hans Christian Jacobi from Sweden. But I want to draw your attention. All of these interventions were diagnostic laparoscopies. Just we insert a device, we look what is inside, and we remove. So no surgical interventions were performed. Nothing was dissected, sutured, coagulated maybe, so it was just diagnostic laparoscopy. So then in 1920, Zelikoffer from Switzerland, he discovered the benefit of CO2 to use for insufflation rather than filtered atmospheric air or nitrogen. So before 1920, oxygen was used, or atmospheric air was used for laparoscopy, and very often burns took place. Why did it happen? Because oxygen, it keeps the firing. Yes, it supports the firing. And in the condition of CO2, firing is impossible. So that's why any energy wave, any like warming, it caused blasting in the condition, in the atmosphere of oxygen or air. And nowadays, certainly we use CO2, and that's why nowadays we don't have such complications. Then in 1938, Jan Virisch from Hungary, he designed spring-loaded needle for creation of pneumoperitoneum. So what is pneumoperitoneum? We'll talk later. Well, in simple words, when we perform laparoscopy, yes, we need to inflate something into the peritoneal cavity, because we know that peritoneal cavity is actually a slit-like space, yes, and so nothing will be visible if we do not inflate, do not expand it with something. And for this expansion, nowadays we use CO2, as I told you, and to introduce this CO2, we use special Varish needle that you will see later. So then in 1966, finally, Professor Harold Hopkins from Great Britain discovered rigid rod length system and cold light source. So yes, nowadays we use cold light for such interventions, such as xenon, for example, xenon lamps, yes, because they are cold. They give much light, but they do not warm, and that's what we need. Like, this is perfect for such type of surgery. And so in 1975, the first organ resection was performed by laparoscopy by Brazil gynecologist Tarasconi. So actually, gynecologists were pioneers in laparoscopic surgery, and still gynecologists, they are the leaders among all the surgeons, though nowadays certainly surgeons, just general surgeons, urologists, actually all the surgical specialists use minimally invasive surgery in their practice. But the pioneers were gynecologists. And so in 1981, the first laparoscopic appendectomy was done by German surgeon Sam. And then in 1994, a robotic arm was designed to hold the telescope, this camera. So nowadays, you know, there are such systems like Da Vinci system. Here you can see it, yes. When it's not compulsory to stay at the operation table, surgeon can be anywhere. He can be in the next room, he can be in the other country, on the other part of the world. The problem is just unstable internet connection, and he can perform surgeries. And that is great, actually, because when you stand at the operation table, it's like complicated, yes, like it's not quite easy to hold the camera all the time for 2 hours. Actually, arms, they get tired very fast due to the static load, yes. Yes, and if you are sitting in a very comfortable position, you can perform surgeries much more successful than staying at the operation table. So, but it's not absolutely new. Actually, this invention was done in 1997, so more than 20 years has already passed. In 1997, a computer-enhanced robotic system was used on a human for the first time to perform some steps of laparoscopic surgery. And so actually, development is going on, and medicine is very rapidly developing science, and you know it, and new discoveries and new inventions are still ahead, and that is great. Okay, so and we have also to discuss actually what are advantages and what are disadvantages of such method of minimally invasive surgery. It has many advantages, but disadvantages are still present. That's why some old surgeons still do not admit this method, but they are very few nowadays. Like now, nearly every good surgeon should master this methods of minimally invasive surgery. Okay, so what are the advantages? The main advantage, and why it actually was invented, it is reduction of surgical scar. And as a consequence of it, certainly it is reduction of postoperative pain. So when we perform laparoscopy, we do not give such patients narcotic drugs for analgesia after the surgery. Yes, we just give them non-steroid anti-inflammatory drugs, and that is quite enough. And then shortening of recovery period. Yes, so at our department, for example, when we perform laparotomy, woman, because I work in the gynecology department, woman stays at the hospital for at least a week. And if it is laparoscopy, then 3 days are quite enough, but in European countries, even there are 1-day surgeries when woman comes in the morning and then in the evening she goes home. Then reduction of postoperative adhesions. Yes, I told you the less incisions are, the less adhesions will be formed. And then zooming, yes, up to 40 times. Like now it's not necessary to wear glasses, yes, to use some special lenses. Everything is already in this device, in the laparoscope, and zooming allows us to perform our actions with better precision, and that is also great. And so opportunity to observe an object from all points of view. So if time is left, we will see, watch some video, and you will see that, yes, if you look into the operation wound, into the laparotomic operation wound, you can observe everything only from superior side. But because now we have laparoscope with oblique end, oblique, this the lens is situated obliquely, so by rotating it, we can observe the organ from all the sides. But yes, there are many, not many, but some disadvantages of this method. So first of all, that is expensive equipment. So some of you bought, yes, like needle holder, for example, for surgical club meetings, yes, or even forceps, yes, for your anatomy classes, and you know that you can buy forceps for about 200 or 300 rubles, yes, and if it is needle holder, maybe it is about 1,000 rubles. But if we want to buy the same equipment for laparoscopic surgery, we can say that laparoscopic needle holder costs 20,000 rubles, so it is several times, 20 times more expensive. And that's why like this distribution of laparoscopic, not only laparoscopic, minimally invasive surgery in Russia, for example, I think in your countries as well, was very slow, because not all the hospitals could afford such an equipment, and the country couldn't, our government couldn't provide all the hospitals with this equipment at the same time. Then it requires additional skills of a surgeon. Yes, so to become a specialist in minimally invasive surgery, surgeon should continue his learning, his or her learning, and it takes time, and it again takes money. Yes, and so palpation of tissues is impossible. It's another, and yes, sometimes very serious disadvantage. If we perform a wide incision, we can touch everything with, no, certainly it's not quite good to touch everything, but if we need to differentiate, for example, if it is a vessel or nerve, if it is a tumor, like something solid, or there is a liquid, we can touch it. In case of minimally invasive surgery, when we just insert very narrow instruments through a small incisions, palpation is impossible. Limited range of movements in operation field. Yes, so it's like when we eat sushi, yes, with this Chinese sticks, it's quite awkward, like quite not comfortable for us, because like range of movements is limited, because we are just holding the instrument at the very end, and we cannot do with this instrument the same as we might do with our hands without this instrument. So yes, range of movements is limited. So these are disadvantages. But nevertheless, we see that there are much more advantages, many more advantages. And so look, what? Here you can see a total laparotomy, total median laparotomy. And so you see, yes, we see everything, all the organs, but it is actually the surgery that made a person to be invalid for a very long time, and you see what an ugly scar is left. And now you can see that actually all of these things can be observed during laparoscopy. So you see 4 small holes, 1 for the camera and 3 for the instruments. And you see that 7 days after the surgery, you, like patient, cannot even remember where exactly these holes, these incisions were done. Yes, so for the patient, obviously, laparoscopy is much more preferable than laparotomy. So what is the difference for the surgeons, for us as the surgeons, in case of laparoscopy and laparotomy? So first of all, surgical approach is different. In case of normal or broad, like I'm talking about laparoscopy because just it's more habitual for me, like I used to it, but actually what I say about laparoscopy is the same we can say about thoracoscopy and all the other minimally invasive surgeries. So in case of large surgeries, or open surgeries, let's say so, in case of open surgeries, for surgical approach we use instruments which we saw at our surgical museum. Yes, those are the scalpel, scissors, maybe some other instruments for the dissections. In case of this minimally invasive surgery, for the surgical approach, we usually use Verish needle or trocas. So Verish needle, here you can see it is a very thin needle. You push it through all the tissues and reach peritoneal cavity, and then through the special opening, gas enters peritoneal cavity and it inflates peritoneal cavity, and so after that we can introduce all the other instruments. So this is classic method by Verish needle. Nowadays, not all the surgeons use Verish needle for the surgical approach. We can use just trocar. So we take this cannula, this is cannula, we insert trocar inside. No, it's like the same method as during, principle is the same, like during catheterization of veins by Sildinger technique. Yes, I hope you studied it in surgery. So we take a cannula, we insert a trocar inside, and then we take cannula with trocar together, and what are we doing? We rotate the trocar, like we push and rotate the trocar until we pass through all the layers of abdominal wall, and when we enter peritoneal cavity, we will just understand it by our feelings. We will remove the trocar, and instead of the trocar, we will insert any instrument. Such a method of surgical approach is known as blind way, and it may have some serious complications. Here you can see it, because we do it blindly. In case of adhesions, we can accidentally get into the intestines, for example, or maybe into a vessel, and yeah, it's very dangerous, and it may cause even death of the patient. But rate of such complications certainly is not very high, but still it is present. And that's why nowadays the newest, the latest, the recent invention was optic trocar. While we enter, pass through all the layers, we can see all of these layers, because at the end of the trocar there is a camera. I will try to show you this video if I can. So look, here you can see it. So you see that we pass through the skin first, and then it is obviously subcutaneous fatty tissue, and then so fascia, yes, aponeurosis, fascia, yes. And so finally, yes, we are reaching peritoneum. And so you see they are different in colors. It's quite easily to distinguish them. And so then, yes, we saw mental appendages at the very end. So it means, yeah, you see it? Yeah, and it means we are inside. So certainly this optic trocar, it decreases chances of such complications much, but again, everything has its price, unfortunately, and not all the hospitals in Russia, at least, are still provided with this equipment. But we are trying, we are doing our best. Okay. So then, yes, after we perform surgical approach, after we inserted all the instrument, no, the first just camera, we start to create pneumoperitoneum. Pneuma means air, yes, peritoneum means peritoneum. So, but as I told you, nowadays the most common insufflation medium is CO2, carbon dioxide, yes, and the average intraoperative intra-abdominal pressure is 8 to 15 millimeters hydrarchium. So through the special tube, we have special balloons with carbon dioxide. We start to expand peritoneal cavity to improve our vision, and after it is expanded, we insert the other instruments. So which complications can we deal with at this stage of surgery? First of all, gas embolism risk. Gas embolism risk. Because in case if any vessels were damaged, if gas goes to the vessels, yes, we can have a gas embolism. But again, percentage of this is very low, but still it is present, and there is no chance to avoid it anyhow. But I'm telling you, it's not even 1%. It's less than 1 promille. Yes. So then postoperative pain from insufflation. Why does it happen? Yes, it happens due to the phrenical symptom. Very often patients after the surgeries, after the laparoscopic surgeries, have complaints about the pain in supraclavicular region. Why does it happen? It happens because gas, CO2, is light, yes, and as any gas, it tries to go upward. And so what is the superior boundary of abdominal cavity or peritoneal cavity? It is a diaphragm, yes, it's obviously. So, and this gas starts to compress the diaphragm, and we know that phrenic nerve supplies the diaphragm, yes. And we also know, I hope that we know all of these things, that phrenic nerve is a branch of cervical plexus. And we, in this case, deal with such irradiated pain. Irradiated pain, what does it mean? It means that, yes, patients feel pain at the region of diaphragm, but much more pain they feel in the supraclavicular region, and they cannot explain it anyhow to themselves. And so in this case, we need to calm down them that it's fine, that the gas will be absorbed very soon, 2 or 3 days later. And yes, it's one of the actually unavoidable we cannot even call it always complication, because it is impossible to remove all the air, like all the gas, all the carbon dioxide after the surgery from the peritoneal cavity, because incisions are very small. But such complications are most common in very thin people, because like people with, let's say, moderate development of fatty tissue, they do not suffer from this much. So then subcutaneous emphysema. Subcutaneous emphysema, it is also possible when we didn't insert the trocar completely to the peritoneal cavity, and when gas can go away to the subcutaneous fatty tissue, and then this gas can damage small vessels in the subcutaneous fatty tissue, and bleeding start, and then hematomas will be formed. It is also possible. And we feel, when we palpate these regions of emphysema, we feel crepitation, like crepitation. I hope you understand what I mean. Yes. And then, yeah, respiratory failure. It is the most severe complication of such type of surgeries. It is caused by very high pressure in the peritoneal cavity, and that's why anesthesiologists, they look after this very attentively, and they always force surgeons to decrease the pressure, because if pressure is very high, then diaphragm compresses the lungs, yes, and lungs cannot be expanded, ventilation is not efficient, and yes, it will finally cause respiratory failure. Such complication is also possible. These are the complications which are associated with creation of pneumoperitoneum. So yeah, after we created pneumoperitoneum, we inserted laparoscope. So laparoscope, here you can see it, or no, just camera. It is rigid endoscope, which is made of an outer ring of optical fibers used to transmit light into the abdominal and pelvic cavity, and an inner core of rod lenses, by which the illuminated operative field is captured by a camera. So yes, by this laparoscope, we are observing, and we are also lighting. Yes, we give the light, provide the lighting to the peritoneal cavity. So it's not compulsory that it will be rigid. Nowadays, flexible endoscopes are also very popular, and they are much more physiological. But in laparoscopy, we certainly prefer solid, rigid endoscopes. And in case of endoscopy, we will talk about it later, when we enter through the natural orifices, certainly flexible endoscopes, they are preferable. So then, yes, certainly cold light source is compulsory in this type of surgery. We have already said about it. And camera. So yes, we use, as I have already told you, argon and xenon to illuminate, to illuminate peritoneal cavity. Not only peritoneal cavity, any cavity where we are performing a surgery. Then there's a difference between open surgery and this minimally invasive surgery is in the fact how exactly we will wash and dry organs in the cavities. Yes. So in case of open surgery, sometimes we use, we just take a glass, sterile glass, of course, where there is a sterile natrium chloride solution, saline solution, yes, and we just pour the solution into the cavity, and then with special cotton tissues we dry it. Yes, so here it is again impossible because there are very small incisions, and that's why for this occasion, for this purpose, we have suction irrigation pump. So special system of tubes, like for device, and it is connected by tubes with bottle with solution, yes, and with a special another bottle where aspirated liquid is collected. And yes, then we have special this irrigator, suction irrigator. And through this tube that can be inserted through the cannula, solution can enter the cavity, and also it can be aspirated. Yes. And again, it is like if we can buy this cotton tissues and this glass for like very small amount of money, then this device, it costs rather much. So that's why minimally invasive surgery is not a cheap thing. But I want to tell you that in Russia, we do not ask for any additional money for the method of surgery. Like in some countries, I heard there is such a difference. Like if you want to perform laparoscopy, you need to overpay. Yes, you need to pay more. In Russia, we don't have such a difference. Like we choose that approach which is preferable for the patient without any money dependency, yes, for any financial dependency. Okay, and so yes, here you can see instruments. Oh, well, yes, we saw some of them, I think, at our museum. So what is the main difference between normal instruments? Like they are long and narrow, yes, and the longer the instrument is, we know it, the more complicated the harder it is to use it, because our hand and the end of the instrument is very far from each other, and to reach the balance it's much more complicated. So here you can see it. And again, I want to tell you they are very expensive. The price of one instrument is about it starts from, let's say so, from 20,000 rubles, and then it increases depending on the brand, depending on the producer, manufacturer of this instrument. So the other compulsory system that is used in surgical interventions, not for diagnostic, but for surgery, for healing purpose, yes, it is electrosurgical unit. Electrosurgical unit. By electroenergy, we can work in two regimes. It can be cutting, dissection, yes, and it can be coagulation or cauterization. So dissection, when we dissect the tissues, separate them from each other, yes, and coagulation, we use it for connection of tissues, we use it for hemostasis, for bleeding arrest. In this case, we use coagulation or cauterization. So there are two types of electrosurgery which are used nowadays, but gradually. Bipolar surgery, it substitutes monopolar surgery. Why? I will tell you. So what's the difference? Monopolar electrosurgery was the first to be invented. The sense is the following. So there is an active electrode from where energy, like this plus, yes, there is plus and there is minus. So active electrode, that is plus, and that is working electrode. And when we start cutting, when we start dissecting, or when we start to coagulate, this energy goes from plus to minus, and passive electrode or patient return electrode is located somewhere on the body of the patient, on the body surface of the patient. And we see that this electro energy, it goes and it passes through all the tissues of the patient, and it warms and it can burn. But certainly the highest temperature is at the active electrode, yes, and the further we are from it, the less temperature is. The sense of bipolar electrosurgery is when plus and minus, they are located in the branches of the instrument, and that's why energy passes just between two branches, from plus to minus, between two branches. And certainly we understand that it is safer because this energy does not pass through all the tissues of the patient. Yes, bipolar electrosurgery was invented later, and now it becomes more and more popular, but still I want you to know there are some advantages in monopolar electrosurgery as well. So what's the difference? Yes, in case of monopolar electrosurgery, active electrode is on the instrument and passive one is on the patient, I have already told you. And for the bipolar, active and passive electrodes are on the instruments together. And that's why for the monopolar electrosurgery, there is higher opportunity of injury of adjacent tissues, it's obviously. And for the bipolar electrosurgery, such opportunity is very low. But in case of monopolar electrosurgery, both dissection and coagulation are possible. And for the bipolar, only coagulation is possible. That's why usually for the dissection, in case of bipolar electrosurgery, we use scissors, or maybe we can switch to methods from monopolar and bipolar, and it takes additional time. And so for monopolar, higher voltage is required, and for the bipolar, lower voltage. And for monopolar electrosurgery, it can be used for both small and large bites of tissues. So for example, we have a bleeding, and large artery is bleeding, and we should stop this bleeding, and we do not see anything, blood is everywhere, and we have no time, then we have no other option than to use monopolar electrosurgery. Because in case of bipolar electrosurgery, it can be used only for small bites of tissues. And for that, we should first remove this vessel that is bleeding from all the adjacent tissues. We should remove the fascia. We should separate the other maybe vein, from nerve from it, and only to take a very small bite and very precisely to coagulate it. So bipolar electrosurgery requires a special, additional skills from a surgeon. Surgeons should be very delicate to work only with bipolar energy. But it is possible. Yes, nowadays, bipolar electrosurgery is becoming more and more popular. Okay. Okay. Yes, what is for the surgeon? Yes, for the surgeon, it's not quite easy to master this minimally invasive surgery, because we used to look with our eyes to the object of our labor, yes, of our action. And here is something different. We are working somewhere in the cavity and we are watching on the screen. And for the first time, when you just start to do it, I hope this semester we'll go to a simulation center. If not, we will go there next semester. It's compulsory. And so you will try to do it. So you will see that it is absolutely new experience. Like brain should work in a quite different way. But yes, and adaptation maybe can take a definite time, but anyway, it is, again, there is nothing impossible, yes. But yes, it is one of the difficulty that surgeon will deal with when he begins to master minimally invasive surgery. So hand-eye coordination is quite different from a real life. Yes, here you can see how we attend with another student simulation center. One more. Yes, and so training of these minimally invasive surgeons, it takes time, and still there are some researches, now it is very popular, and even there are some results of researches that if surgeon played video games in the past more than 3 hours a week, then he makes 37% less errors and he works 27% faster. That's why in some articles, even scientific articles, it is recommended to use video games as a teaching tool for the residents. But it doesn't mean that you will play this PUBG all the time. Yes, it's just an opinion of some scientists. Yes, it's like useful, but it doesn't mean that instead of studying all the subjects, you will just play video games. And so, yes, as I told you, nowadays, laparoscopy is rapidly developing, and it occupied its very significant place in surgery, and in some cases laparoscopic surgeries are considered to be even gold standard. Gold standard means the best option for the surgery. In which cases it is cholecystectomy, removal of gallbladder, yes, adrenalectomy, removal of adrenal gland, salpingectomy, removal of uterine tube, I hope you understand all of these words, yes, splenectomy, adnexectomy. Adnex means uterine appendages, yes, removal of ovaries and uterine tubes together. So in these cases, we always should prefer laparoscopy. There are surgeries with obvious advantages over open surgery. These are surgeries on colon and hysterectomy. So in hysterectomy, it is removal of uterus, yes? In this case, laparoscopic surgery is better than open surgery, but always we should consider every case individually. Like if, for example, there is a uterus that is very much enlarged due to numerous myoma, it occupies the whole abdominal cavity, and you have just completed your residency, so you are not very experienced surgeon, you shouldn't use laparoscopy in this case, because the harm for the patient will exceed the use for him, yes? So you should always estimate your experience and particular clinical case. And only when you decide that your experience is sufficient and clinical case is not so much complicated, then in these surgeries, you should choose laparoscopy. Laparoscopic surgeries which are equal to open surgeries. These are cases of appendectomy and treatment of anterior abdominal wall hernia. It's very interesting, yes? Why, in the case of appendectomy, open surgery and laparoscopic surgery is equal? Like it's very short surgery, yes, and so why not, and very small, and actually in most cases it's not so that hard, yes. Why should we prefer laparotomy? It is due to the anesthesia, because laparoscopy always requires general anesthesia. And if we perform laparotomy in case of appendectomy, as well as for herniaplasty, treatment of anterior abdominal wall hernia, we can use local anesthesia. And certainly local anesthesia is much more preferable than general anesthesia. And so in this case, probably we should explain the patient that a small scar after the appendectomy, for example, won't hurt him much. Yes, but sometimes it's very complicated to convince a woman in something. Okay, classification. Yes, for all of this time, during all this time, we were concentrating on the laparoscopy, but actually it's not the only minimally invasive surgery. So laparoscopy, in Greek, laparates abdomen, and scopus means to see or view. So it is minimally invasive surgeries on the organs of abdomen and pelvis. There is also thoracoscopy. It's minimally invasive surgery on the organs of thoracic cavity. And arthroscopy, minimally invasive surgery on the joints. And then endoluminal or endoscopy, it is minimally invasive surgery in the lumen of a hollow organ. So when we do not create any incisions, we just enter through natural orifices. Yes, bronchoscopy, in this case, we can enter through oral cavity or even through the nasal cavity. Yes, hysteroscopy, when we enter through the vagina, esophagogastroduodenoscopy through the oral cavity again, etc. Yes, there are many different methods of endoscopy. And so the others, such as removal of thyroid gland through just some incisions in the neck region, appendectomy, and cholecystectomy through the orifice in the wall of stomach. So we perform, like we enter through the oral cavity, yes, we reach the stomach, we make a hole in the stomach, and we can, through this hole, enter peritoneal cavity and then remove gallbladder. Yes, it is also used. There is absolutely no hole in the wall or somewhere on the skin surface, and yes, we should admit that such a method exists. Also, in females, we can perform the same surgeries through the posterior vaginal wall, like ventroscopy that I told you before at the very beginning of our lecture. So thoracoscopy. Thoracoscopy is used as a gold standard for pulmonary decortication, so removal of some peripheral parts of the lung, yes, pleurodesis, lung or pleural biopsies. So when there is a tumor, we don't know yet if it is benign or malignant, so we can take a biopsy by means of thoracoscopy. There are surgeries with obvious advantages, like surgeries on the esophagus. They are usually performed by thoracoscopy. Then mediastinal mass resections, resection of tumors in the mediastinum, yes. And so pulmonary lobectomy for early stage lung cancer, when it is just local cancer, cancer in situ, yes. I hope you understand me. So just we need to remove a lobe, then we use thoracoscopy. When it is cancer with metastasis, with local, regional, and even far distant metastasis, then certainly we'll perform thoracotomy, very wide approach. Arthroscopy. Arthroscopy is used for the, you understand, yes, it is observation, like it is surgery, minimally invasive surgery in the cavities of synovial joints. So it is used for the removal of menisci in the knee joint. It's a very popular surgery, yes. Suturing of menisci, reconstruction of anterior and posterior cruciate ligaments, reconstruction of cartilage, diagnostic arthroscopy just to watch what is inside, yes, and sanation arthroscopy in a case of deforming osteoarthritis. So yes, arthroscopy is very popular. Endoscopy. There are many types, let's say so, many types of endoscopy, like bronchoscopy, when we observe a trachea and then principal bronchi and even lobar bronchi we can reach. We can find some tumor, or maybe we can find some foreign particle and we can remove it. Yes, esophagogastroduodenoscopy is a very common procedure in surgical departments when there is bleeding in the digestive tract. For example, a patient has complaints of the black feces. Yes, so there is a blood in the feces. We should perform esophagogastroduodenoscopy to examine the walls of the digestive tract to find an ulcer, maybe bleeding ulcer. or not to find it, then we'll search for another source of this black feces. Cystoscopy, it is examination, like diagnostic procedure, observation of urinary bladder. Hysteroscopy, it is observation of uterine cavity. Oh yes, and in all the cases when we at the same time not only watch but also remove something, it will be, we should add resection, yes? So if we are just we just examine uterine cavity, in case of infertility of the woman, we usually use this procedure before procedure of IVF. Yes, it is just in vitro fertilization. Then it is hysteroscopy. But if we found some polyp or myoma, so some tumor that we also need to remove at the same time, it will be hysteroresectoscopy. Hysteroresectoscopy, it's always. Okay, and this is hysteroscopy. Yes. What's the difference between laparoscopy and hysteroscopy, like a type of endoscopy? Yes, usually in cavities of hollow organs, we do not use gas. We usually use a liquid. And for the hysteroscopy, for diagnostic laparoscopy, we usually use natrium chloride solution, or for resectoscopy, we use glucose. Why cannot we use natrium chloride in case of resectoscopy? Because it is energy. Yes, it is flow of ions. And natrium chloride, it is very good substance for conduction of this ion. So glucose is dielectric and natrium chloride is not dielectric. That's why via this liquid, via this natrium chloride, this energy will be distributed to all the surrounding tissues and it will cause burn. And that's why in this case we use glucose. Glucose does molecules of glucose, they do not conduct energy. They do not use as, they are not used as energy conductors, yes? So hysteroscopy is used for diagnostics of uterine infertility, as I have already told you, and dissection of intrauterine adhesions, and polypectomy, yes, removal of polyp, it's like benign tumor, yes, and myomectomy, usually submucous. Myoma means that myoma is a tumor from myometrium, yes? Submucous myoma, that one that is predominantly located under the endometrium, so closer to the uterine cavity. So for the removal of submucous myoma, we can use hysteroscopy. If it is subserous myoma, that one that is located under the perimetrium, closer to the peritoneum, certainly we cannot use this method. So what else can we do in minimally invasive surgery? Capsule endoscopy. So what does it mean? It means that there is a capsule, yes, to examine the whole digestive tract. Patient swallows this capsule, goes home, and he eats everything, and this capsule goes along his digestive tract until it reaches rectum. Then he defecates. The main problem is to catch capsule, yes, not to lose it together with fecal masses. And then he takes this capsule, he brings it back to the hospital, yes, and in this capsule everything is actually recorded, the whole movement of this capsule, and then we just watch the video, and if something is wrong, we find this part in the digestive tract and we try to fix the problem. So this is capsule endoscopy. So a very comfortable procedure for the patient. He does nothing, just shouldn't lose the capsule, yes. So endoscopic vessel harvesting. At the previous lecture, one lecture before, we were talking about vascular surgery, yes, and we said that for aortocoronary bypass, yes, for creation of anastomosis, in case of thrombosis in coronary arteries, we can use arteries, like for example internal thoracic artery, yes, but we can also use veins. And in case of veins, we usually choose saphenous veins, greater saphenous vein, for example. And you know that for the traditional vessel harvesting, so to take this vessel, we will make a very long incision on the whole leg, and again it will leave a scar, and it will cause very severe postoperative pain, yes. And so nowadays we again can do this by means of endoscopy. So endoscope is connected to a video camera and inserted through a small incision in the leg. And so it is used to view the greatest saphenous vein inside the leg and allows the surgeon to remove the vein with minimal stress to the leg. And so this procedure generally results in less muscle and tissue damage and therefore decreases the incidence of wound healing complications. So here you can see, yes, what happens, what occurs after the traditional vessel harvesting, and so just 3 small incisions in case of endoscopic vessel harvesting. Yeah, single port laparoscopy. So even recently, not recently, several years ago, like surgeons, they are those people who never stop in their development. And when they master something and they are perfect in something, they every time try to simplify the task, yes? To create new tasks for them. And so now they decided that 3 or 4 incisions is too much, and maybe it's possible to do everything with 1 incision. And so it is known as single port laparoscopy. Just 1 incision with 3 ports, and the camera and all the instruments are entered through these ports. And actually I tried to do this just in simulator, and it's absolutely not comfortable. Like it takes again time to get used to it, and you see in this picture, yes, that surgeons are very close to each other, and their movements are very limited. But for the patient, maybe it's another advantage, not 3 incisions but only 1. Well, yes, it's also one of the newest inventions. Endoluminal surgery, as I have already told you, yes, here you can see that through the posterior vaginal wall, so this is uterus, yes, through the posterior vaginal wall, a cannula and instrument is inserted, and yes, in this case we are trying, so surgeon is trying to perform cholecystectomy through the posterior vaginal wall, so endoluminal surgery. And yes, as I have told you, yes, it is robotic surgery or Da Vinci, when surgeon does not even have to stand at the operation table. He just, they are sitting somewhere, maybe in the same room, maybe in the other room, maybe in the other hospital at all, and they are performing the surgeries. So it's, yes, so laparoscopic, not laparoscopic only, minimally invasive surgery is moving forward, and it's developing very rapidly. And yes, so we have some time. And now let's enjoy one video. So now you will see how beautiful everything looks like through the laparoscopic camera. So look, here you can see, yes, it is actually lateral umbilical fold, yes, through which inferior epigastric artery passes. And so here you can see uterus, yes, uterus with uterine tube which arises from it, and this is ovary, and this is, yeah, you see uterine artery, and ureter passes here, and here obliterated umbilical artery that continues to the medial umbilical fold. So this is white, this is ovary, and this is, you see, round, what? This is round ligament, yes, round ligament of the uterus that goes to the deep inguinal ring and then enters the inguinal canal. And so here, finally, you can see in front of the uterus, yes, this is vesicouterine pouch, vesicouterine pouch. Yes, so this is inferior epigastric artery, lateral umbilical fold, medial umbilical fold, obliterated umbilical artery, and round ligament of the uterus. So you see how it is useful to know anatomy and topographic anatomy for the surgeons, because yes, you see how actually easily it is to damage any of the structures, and it will cause very severe, sometimes not fixed complications. Oh, so here you can see, yes, this is Douglas pouch. Douglas pouch that is anteriorly bounded by uterus, yes, and posteriorly by rectum. So here you can see a place where iliacatory, external iliacatory is crossed by the ureter. Sorry, internal iliacatory, yes, is crossed by ureter. So from the right side, internal iliacatory is located medially from the ureter, and from the left side, it's vice versa. Yeah, this is sacrouterine ligament, one of the parts of fixation apparatus of the uterus. So this is Douglas pouch. Under it, there is posterior vaginal vault, yes? So through this posterior vaginal vault, we can enter this place. And you see liquid. A liquid is accumulated there because it is the deepest place in the peritoneal cavity of females. So again, ureter, yes, uterine artery passes, and obliterated umbilical artery starts from internal iliacatory. Yes, here you can see it. And here you see from the left, internal iliacatory is laterally from the ureter. From the right, internal iliacatory is medially. Yeah, you see? Yeah. Medially from the ureter. And so here you certainly see that this is large, this is sigmoid colon. Yes, it's obviously. And this, oh my, yes, this is like now instrument is in the posterior vaginal vault. Posterior vaginal vault. So fimbria, yes, fimbria of uterine tube. So actually it is amazing. It is especially amazing that when you understand what you see. To understand what you see, you certainly have to know anatomy and topographic anatomy. That is great. Okay, thank you for your attention. I hope you gained something from today's lecture. Any questions? Okay. Okay, so if you have no questions, then see you next time. Goodbye.